Right, I'm from Belfast in Northern Ireland, and we have 3 representatives from Ireland here at CNETS. I'm very proud to be one of them. And I've been at CNETS before, and I'm also very proud to be introducing the next speaker, who is Tony Heany. He graduated in medicine in Belfast in Queen's University, and he was one of our very best students doing a PhD in the Department of Medicine. He's an endocrinologist, and we were very, very sorry to lose him to sunny California. We thought we might tempt him back a couple of times, but that hasn't happened yet. But you're going to be privileged by hearing him talk about circulating markers, and I'll just read this title. Neuroendocrine hormones, why are they important? Tony.
So thanks, Joy, for that introduction, and if I can just thank the organizers and Maureen for putting on this amazing conference in such a, Murphy's Law, my phone goes, this wonderful conference in such a wonderful city. And what I'd like to do in the next 20-25 minutes is basically explain to you why I think that hormones are important in this in these disorders. And as you've heard today, and it's been a theme through the conference, these are very unusual tumors. They occur in many, many sites throughout the body. One of my parallel interests is in pituitary adenomas, which are actually a subgroup of neuroendocrine tumors, but for reasons that have never been clear to me, they tend to be perceived as a separate entity, but they really are very much a neuroendocrine tumor. And pretty much any of the organs you see listed here are all capable of generating neuroendocrine tumors. I'm going to begin by a definition because I think it's important that we understand what we mean when we talk about hormones. And this is a standard sort of dictionary type definition. A hormone is a chemical substance produced in the body that controls and regulates the activity of certain cells or even organs. And that's the definition that I'm going to use when I'm talking today about hormones in the setting of neuroendocrine tumors. Now, it quickly gets more complicated because, as you've heard, not all of these tumors produce hormones, although one has to wonder if that's just because we haven't been clever enough yet to figure out what hormones these are making, and Professor Ardle will enlighten us more about this. When I last looked at this area, there were something like 40 or 50 different peptides that have been characterized from these tumors. So if you take these tumors and you turn them into a soup and do various scientific processes on them, you can find all kinds of peptides in there. Unfortunately, many of these we cannot even measure. Some of them we don't have a name for, and many of them we have really no idea what they do. Some of them were important in the past in teleosts, which are fish, but don't really have a function in us as mammals. Pancreatic polypeptide, I think, is a very good example. And as you've heard today, some of the neuroendocrine tumors in the there's a pointer, in the foregut don't necessarily have all the machinery and enzymes to synthesize serotonin, for example, which is a very important marker in these tumors, but they can make the precursor of serotonin, 5-HTP. The problem is that for a lot of us, it's not easy for us to measure some of these peptides. Certainly commercial labs don't run them routinely. So this is an overview of what I hope to share with you. I want to try and convince you that hormones do have a role in the diagnosis of neuroendocrine tumors. I think they can actually help guide investigation, help locate primary tumors in many instances, and potentially, therefore, they can limit cost, which, as you know, in North America is becoming a very important issue for all of us, and we're facing a time when we may have to think even more about some of the expensive tests that we offer to patients. And as you've heard, it often takes a lot of testing to find these tumors. I'll discuss with you how these hormones can correlate with clinical symptoms, and in fact they could be the direct cause of the clinical symptoms in many, many cases, and how that helps prompt timely key evaluations and interventions, assuming the hormones are measured and heeded to by your healthcare professionals. And as some of you may know, they may even have a role in predicting survival, and I'll show you one or two examples of this. And I'm going to use a kind of a case vignette type format. So this is the first case, and this is an example, I would say, of how measuring hormones can, not to overstate it too much, but can actually save lives. So this is a very typical story. A 69-year-old with a previous heart attack in 2005 had documented valvular heart disease. AR is the aortic valve, MR is the mitral valve, and TR is the tricuspid valve. And this thing called EF is basically how the heart muscle works. Normally the heart muscle pumps about 70% of the blood out with each beat. And as you can see in this case, this patient had impairment of the function where the ejection fraction was 47%. So he was being followed up by his cardiologist, and he had noticed some recent increase in breathlessness. And he underwent an echocardiogram, and just as the technologist was kind of looking down under the heart, they noticed that in the liver, as well as being enlarged, there seemed to be these unusual masses in the liver. So a CT was done, and this revealed that these were actually metastatic deposits, and there was some fluid in the abdomen and some in the chest. And this patient, along the way, had had an exploratory laparotomy some years ago, at which point a sort of dysplastic polyp was found, and a small part of his ileum had been removed. But on questioning, this patient actually had altered bowel habit for 12 months, mainly diarrhea, pretty impressive, as you can see, 15 to 20 stools a day. And also his wife had commented that he'd begun to flush in recent months. And he had been at the ER recently several times with severe spasmodic abdominal pain. So typically we would do a biopsy of these metastases to try and find out what was going on, and the FNA that was done showed that this was a carcinoid tumor, a fairly typical, as you've heard today, description of pathology, a well-differentiated neuroendocrine carcinoma. And this actually on the right side is his echocardiogram, and I'm sorry I don't have a pointer, but what you see here on the top part, these waves are the normal direction of flow. Whereas you can see on the lower part there's this kind of jet of blood, and that's blood leaking through the tricuspid valve, which is abnormal. So this patient, with the information we now have, we realize that he has carcinoid syndrome. And carcinoid syndrome typically refers to tumors originating in the midgut, which I like to call the classical midgut carcinoid, the classical carcinoid syndrome, and this is due to an excess of a hormone called serotonin. And serotonin is made in these cells. It's made actually from tryptophan that we take in our diet, and the serotonin is then released locally into the gut, and that's what causes the cramping and some of the early diarrhea, etc. And eventually it's taken in the blood to the liver, where it's broken down and then released back into the circulation in a metabolite called hydroxyindoleacetic acid, and that's the thing that your doctors will measure in the urine. And the serotonin is responsible for a lot of the features of midgut carcinoid syndrome: the flushing, the wheezing, the cardiac disease, and the bowel disturbance, typically the diarrhea. And this patient, as we might expect, had elevated serotonin metabolites at 30 and 46. Typically up to 6 would be considered normal. So we want to ask them, why do patients with carcinoid get cardiac disease? And I think one of the best ways I can illustrate this to you is to show you what happens in the heart when you remove the receptor which serotonin binds to. So as you know, sometimes in medicine, when we're trying to figure out how things work, we knock out a gene. And this is a mouse where the receptor that binds serotonin has been basically knocked out. And what you see here on the bottom left-hand panel, on the left side, these are mice. These are actually embryos of mice in which the serotonin receptor gene, the 5-HT2B, has been knocked out. And you can see that there's some redness in the center of this little mouse embryo, and that's actually bleeding into the pericardial sac. And many of these mice don't even survive to be born. But these are mice that have actually been born, and they're a little older. And again, on the left side is the knockout mouse, and on the right side is a normal mouse. And what I think you'll agree is that the red muscle in that heart is much, much less in the serotonin receptor knockout mouse. So this explains to us that serotonin is actually very important in the heart, not just in mice, but also in humans. And serotonin, as shown in this schematic, will actually make the fibroblast cells on the surface of heart valves grow, and that leads to thickening and impairment of the valves. And this is actually a valve from a carcinoid patient, and the actual thin section here on the left-hand side, the tail, if you like, is actually the normal valve, But this whole area, the sort of nubbin at the right side, is proliferation of serotonin-driven proliferation on the surface of that valve. So it's really no wonder that these valves don't work very well. So this is a study looking at 64 consecutive patients with midgut carcinoid syndrome. Echocardiography was done in almost all the patients, 52. And as you can see, a large number of them had valvular abnormalities. 65% had abnormalities of the tricuspid valve, and about 20% of the pulmonary valve, which supplies blood to the lung. And the reason I want to show this to you is that the main prognostic indicator in terms of survival was the severity of valvular damage. Although because these patients were all evaluated carefully in a multidisciplinary setting, as we've heard a lot of discussion about today, although advanced cardiac disease was common, only one patient actually died from right heart failure. And this so-called Kaplan-Meier plot looks at survival, and basically the higher you are on the number on the left-hand side, the more people are alive. And I don't want you to labor on this, but what this basically showed was that the more severe the cardiac disease was in the setting of carcinoid syndrome, the less time you were likely to live. Not only that, but again, back to the question of hormones and markers and neuroendocrine tumors, but the urinary hydroxyindoleacetic acid excretion, the metabolite of serotonin, also correlated with survival. So if you had a really high urinary hydroxyindoleacetic acid, your survival was significantly lower than others. So I would put it to you that hormones are very important in terms of predicting survival, predicting heart disease, and should be measured and measured frequently in all neuroendocrine tumors. Not only are they important in relation to cardiac disease, but coming back to our patient, and we've heard earlier about the difficulty sometimes in finding these tumors and how Dr. Pommier uses these interesting and exciting laparoscopic techniques to walk the bowel. But they're often very small and very hard to find, and you'll hear more about this in the course of the meeting. But this is this patient's tumor, this little sort of nobbin, which was less than a centimeter in size, which was seen on a capsule endoscopy, and this is the primary tumor. This kind of almost like the inside of a passion fruit or something here in the bowel. This is the primary tumor. Now, the reason hormones are important in this setting is because not only does the serotonin cause proliferation in the heart, but it causes proliferation in the gut. And you've heard today discussions about the mesenteric fibrosis, the obstruction that occurs in the setting of carcinoid, and that is caused by serotonin. And these are three examples of patients, some arteriograms, the one on the left, the CT, showing the kinking and destruction that occurs in the vessels leading to abdominal pain and sometimes bowel obstruction. And as you've heard very elegantly from Dr. Pommier, this is one of the unusual settings where resection of the primary tumor is recommended, even in the presence of metastatic disease. So I would say to you that in this case that we've just looked at, the hormonal marker assisted in the diagnosis. Because it was serotonin, it gave us some clues as to where we might go to look first for the primary tumor. There are certainly situations in the pancreas where you can see serotonin overproduction, sometimes even in foregut tumors, but most commonly it's in the midgut. Therefore, it guided the investigation and perhaps even limited cost. And it also explained a lot of the clinical symptoms, and in this case, because it prompted cardiac evaluation, it probably helped extend the survival of this patient. So here's another case. This is whenever our fellows at UCLA are complaining about being tired, I remind them of this patient. This was a 50-year-old flight attendant who used to actually drive from Santa Barbara to LAX. She flew the overnight to Hawaii, then came in about 5 a.m., drove to Santa Barbara, took her kids to school, took a few hours of rest, and came back down again to do the same again the next night. And for 12 months, she had had these mostly transient neurological symptoms, slurred speech, altered level of consciousness, etc. And I have to say I'm embarrassed to admit that some of her doctors thought this was just postmenopausal symptoms. So for many months, she was almost ignored with her symptoms. And then one day, she was taking her daughter to a tennis lesson, and her daughter became alarmed when she was driving down the Central Divider in Santa Barbara and suggested that the daughter should drive instead of mom. And sometime later, she was found unconscious with a blood glucose of 24 milligram per deciliter. Fortunately for her, an astute EMT thought immediately of low blood sugar and measured this. Now, her labs at that time were suspicious, but in hindsight, and we always know in hindsight it's easy to make diagnoses, but I think her physicians could be forgiven at the time to not immediately think of insulin-secreting tumor. And I say that because her blood glucose was certainly very low, but her insulin was not as high as one might typically see in the setting of these insulinomas. However, what is striking here is her proinsulin at 16.3 picomoles per liter, which seemed very high. And there are various criteria that we would use to make this sort of distinction. But as someone has pointed out earlier, these tumors can often be quite hard to unmask. So she actually, this is about a year later, she was continuing to monitor her blood sugars, and this just outlines a day for her with her meals, etc. And what we see here is that about an hour, 45 minutes to 60 minutes after she eats, her blood sugar falls. And this is what in endocrinology we would call a reactive type hypoglycemia. And so one of our doctors did a glucose tolerance test, and sure enough, it showed the pattern of a reactive hypoglycemia. And the reason I show you this is because these tumors are highly differentiated, and they respond almost at times in a normal way to the administration of sugar, and they're able to up and down regulate their hormone production. So sometimes they can be very hard to detect. So what we do sometimes in this setting is we do a dynamic test, and this is what we call a 72-hour fast. So this lady came down to us. She left Santa Barbara. Her blood sugar was about 70, which is just in the normal range. And by the time she got down to UCLA, her blood sugar was already 40, so we didn't really need to fast this lady very long. Her tumor was making itself very clear. And what you see here in the red line is her blood glucose checked every hour, because that's what we do in this test. We don't let people eat anything. They're allowed to drink water and unsweetened tea, but they're not allowed to eat any food, sometimes for up to 3 days, because it may be necessary sometimes to carry out that test to find these tumors. And once we were sure of the diagnosis, we then give her, you'll see this D10 infusion, which is really a high sugar solution. One other comment I want to make, and again, this is 20/20 vision, which is always easy for, typically the tertiary referral centers have the benefit of the 20/20 vision, but this lady had had a CT scan of her abdomen early on in her evaluation, about 2 years before we actually met her, and it was reported as normal. And I have to say that our radiologist at UCLA also thought it looked normal. But when we did an MR scan, you could see clearly labeled with this arrow that there was a lesion, probably about 0.4 centimeters in the just in the neck of the pancreas. And on hindsight, looking back at the CT, that lesion had been there also at that time. So this really just, again, to emphasize, and this will come up in some of the radiology discussions, but there are certain dedicated protocols that need to be done by the radiologist to find these often very small tumors. So the tumor was removed, and that's what's marked here in this surgery. It was removed laparoscopically, just enucleated out, and you can see very quickly the blood sugar bumped up actually into diabetic range levels, which is not untypical in this situation. And then, as I think it was Dr. Warner commented this morning, the sort of the proof in the pudding that you really have got the lesion is to immunostain the tumor for the hormone that you think is in excess. And here is the insulin staining in the bottom panel here, showing that this is positive. Okay, this is, I don't think I'm going to have time to cover everything, but this is another interesting case. This was a lady in her 50s who presented with abdominal pain, had a tumor, a midgut carcinoid tumor removed, and as is not infrequent, she did not have any markers measured. So I can't tell you what her serotonin metabolites were at diagnosis. But when we met her, she was advised she'd been free of disease, and we did her markers, and you can see here that her urinary hydroxyindoleacetic acid was actually quite elevated, and we were concerned that there was still residual disease. So she went to the OR for a re-exploration, and there was no evidence of local disease, But when the liver was examined, and it had to be examined by ultrasound, she actually had a lot of disease in the right hepatic lobe, which was resected. And then her hydroxyandilacetic acid, the serotonin metabolite, returned to normal. And you can see it stayed normal for 2, 3, 4, 5 years. And we followed her serially. This is her MR at 4 years. At 5 years, everything was fine. And then at 6 years, her urinary hydroxyandilacetic acid bumped up just out of the blue. And sure enough, when we did her scan, she had some early recurrence on that scan. And so this marker, this hormone, was actually detecting her disease earlier than her scans. And that disease was radioablated under CT guidance, and this is her scan about 6 weeks after that, and her urinary hydroxyandilacetic acid came down again. So really to say that these markers do give us a very important insight into what is going on with these tumors. And if you look at a larger series of patients, they correlate very closely with the extent of disease. So if you have more than 5 liver metastases, for example, with a midgut carcinoid, you're going to be at the far right of this panel. There's a wide range in the levels, but the more disease you have, the greater burden of disease, the higher the hormones typically will be. I'm going to skip that case and go to this one. This is an area, just to finish on a sort of controversial note, because this is something which I know Professor Ardle will speak more to, but this is what to do with the patient with elevated chromogranin A, because this is a group of patients that I not uncommonly see. So this was a 38-year-old patient. She had some vague abdominal pain symptoms, recent diarrhea, not very prominent, and some significant weight loss. And the interesting thing in terms of labs was that her chromogranin A was elevated, as well as her pancreatic polypeptide. And one of the questions that comes up is what to do with these kind of patients if they don't have anything. Typically, they'll already have had some functional imaging studies, octreotide scans, CT scans, etc. And the question I often have to think about is, well, how far do we go chasing this chromogranin A? And so the question comes up, how good is chromogranin A as a marker? So there are many studies on this, but this is one that is relatively recent and I think quite helpful. So these were 280 patients. They were somewhat selected because they had shown up, they had symptoms which led them to come into a GEPT tumor clinic in Italy, and they all had baseline ultrasounds, CTs, octreotide scans, endoscopic ultrasounds, etc. And if there were any tumors found, they were biopsied and characterized, etc. And basically there were 3 groups. There were 238 of these patients had neuroendocrine tumors in various sites. 42 of these patients had a condition called atrophic gastritis, and 48 were healthy patients. None of them had renal impairment, which is one of the things that can cause false elevations in chromogranin A, and the majority of them, apart from those with gastrinomas, were not on proton pump inhibitors, which is another cause of elevated chromogranin A. And they had a fasting lab. The normal range they don't actually give in this paper, but calculating it from the information in the paper, it seems to be a mean of about 10 micrograms per liter. So this is what they found in these patients. So these are the neuroendocrine tumors on the left. The patients at the most left side are patients who are disease-free. Those next to that, the LD, have local disease, lymph node involvement, etc. The next group have hepatic disease, and then the final group, DD, have diffuse disease. And then we have a group of patients with chronic atrophic gastritis, either with or without hyperplasia, and then we have the healthy patients on the far right. Now, one of the first things you have to point out here is that there's such an overlap in chromogranin A levels in these patients, and that's one of the real problems I think that we face with chromogranin A, and one of the reasons that we sometimes become very frustrated with this assay. So to make some sense of that, they then went on to sort of ask the question, the one that I posed at the start, what level of chromogranin A should we get concerned about? What level should we go to investigate? And the cutoff that they came to in their assay was around 84, which equates to a 4-fold increase. And they concluded that if there's a 4-fold increase in chromogranin A, then that should be investigated with specific testing for neuroendocrine tumors. Any less than that, you're in a kind of a gray zone where there could be overlap with a lot of non-neuroendocrine related problems. Now, when I see something like this, it doesn't really surprise me because in endocrinology in general, for many assays that we use, unless we see an elevation that's 3 to 4-fold, we are not really convinced that someone has the disorder. So if we're looking at Cushing's syndrome, for example, if we see a urine cortisol that's 1.5 times elevated, 2 times elevated, whatever, that's not very impressive. If we see a level that's 3 to 4-fold elevated, it almost always indicates that somebody has hypercortisolism, and we go on to further investigation. So I would put it to you that chromogranin A is not so different. If we're looking at 2-fold elevations and so on, then yes, there are major concerns. But if we have a patient with a 4-fold plus elevation in chromogranin A based on the normal range for that assay, that's a patient who is worthy of significant investigation before we decide there's nothing amiss. So to kind of summarize and sort of to go with the theme of the talk, which is why are neuroendocrine hormones important, I would put it to you that they assist in the diagnosis. I think this is very important given the rarity of this disease. The fact that these tumors are slow growing and indolent, there are many in this room who can attest to that, and that, as we know, they overlap a lot with much more common disorders, particularly irritable bowel syndrome in the setting of midgut carcinoids. I think they can help locate the primary origin. They can allow us, your doctors and healthcare providers, to come up with a strategy for focused application of techniques in the diagnosis. And as I mentioned, that can potentially limit cost. And of course, they are in many instances the direct cause of the clinical manifestations. The serotonin causing the heart disease, the insulinoma, the insulin production causing hypoglycemia, etc. Many of these are found incidentally, and therefore it's important that we have some methodology to figure out which of these incidental lesions need to be dealt with and which can be left alone, because the incidental oma incidence, which is the name we give for things, lumps and bumps that are in there, which just are doing nothing, is very, very high. The other thing that I think they can help us with is to track the therapeutic response as part of your treatments and also help in predicting survival. So I'm going to stop there, or else Maureen's going to come up and beat me. Thank you. Thanks.